The topic of the Armenian American Health Professionals Organization, AAHPO's recurring health event and dinner was plastic and reconstructive surgery. The fascinating, informative lecture titled Botox Fillers, Facelifts, and much, much more. Everything you wanted to know about plastic surgery but were too timid to ask. The lecture was presented by renowned board-certified and fellowship-trained plastic surgeon K Markarian, MD, MSPH. Dr. Markarian, who practices in Wellesley, Massachusetts, is a graduate of Medical College of Georgia. Dr. Markarian completed residencies at St. Louis University, Texas Tech School of Medicine, and University of Nevada School of Medicine. He completed a fellowship at Beth Israel Deaconess Hospital. Held at Cornetta's Restaurant and Marina in Piermont, New York, the event drew large audiences of AAHPO's physicians as well as members of the Armenian community at large. Dr. Markarian began his lecture by describing the nature of his practice, 90 to 95% of which are aesthetics and 10% reconstructive surgery.
About 90-95% of my elective practice is aesthetics, and the rest is reconstructive. When I take call, it's all reconstructive. So I operate on head-to-toe, face, trunks, extremities. Face can be everything from rhinoplasties, nose jobs, to facelifts, to blepharoplasties, which are eyelid surgeries, and yes, Botox and fillers too. As far as the body goes, the trunk, I do tummy tucks, I do liposuction. With those tummy tucks, I do surgeries on the breast, where it's an augmentation, which is an implant, a lift. I do reductions. I do gluteal contouring with fat grafting, the Brazilian butt lift. We'll talk about that as well. And I do arm lifts and thigh lifts, and we'll talk about that as well. As far as reconstructive surgery, I operate on the face, the breast, the tummy, hands. I do Mohs surgery, I do trauma reconstructions, I do tissue expander-based, implant-based reconstruction for breast cancer. And then I do some complex hernia repairs, and I do a ton of hand surgery when I'm on call.
It was eye-opening to hear Dr. Markarian describe all of the details that go to face and body reconstructive surgeries, including the complexity of biology of the facial vascular systems, precisions required during the surgery, and much more.
I really enjoy doing rhinoplasty, really enjoy nose surgery, and there's a lot that goes into it, and I think when it comes to, if you can compartmentalize it into this, the face is a game of millimeters. The breast could be basically a game of maybe a centimeter here and there, and the belly could be a game of inches. By that I mean the amount of precision that you need in the face is quite overwhelming. I mean, so if you were to sew up a little boy came in with a lip laceration, you sewed him up, and the vermilion border, which is the interface of the red and white, was off by about 1 to 2 millimeters. That's noticeable at a conversational distance. It actually looked like they had a cleft lip if you don't sew it up together. So the precision has to be incredible. And noses, it's such a thing where an aberration on one part of the nose will affect how something else looks. If the nose is more depressed here, the tip looks like it's longer when you didn't even touch the tip. And I'll get into all that. Whenever I do any kind of nose surgery, I have at least, if not a visual diagram, I have a mental diagram of all the different things I have to do, whether it's something I have to suture, cut out, graft, or bones that I have to break, do osteotomies. I construct this plan before going in, and things don't always go according to plan, but at least you have a framework, okay? You go in, someone has a scarred nose, they got into a trauma when they were a kid, the cartilage is warped, you can't use it. There's different things that happen.
Dr. Markarian also touched on the difference between male and female aesthetics, bringing work on the nose as an example.
There's a different aesthetic ideal when it comes to men. There's a different aesthetic ideal when it comes to female noses. Typically, the male nose is wider and straighter. It doesn't curve. It says here, there's less concavity at the superciliary ridges, basically above the eyelashes. It's straighter down. It's actually ahead of the female dorsum. That's how the female's nose is, and that oblique line shows where the male nose should be out more, not more of a ski slope, but more straight, like we were saying. some call a super tip break, which is basically, I'll skip this, it's basically the little tip right there should have a little bit of a bump.
During his lecture, Dr. Markarian spoke about the category of clients he considers difficult to please, including the ones with the unrealistic expectations and body dimorphic syndromes.
Red flags. So patients whose degree of concern exceeds deformity. Has anyone ever heard of the acronym SIMON? Self-absorbed, immature, male, overly narcissistic. Men are a little less than 10% of my patients. The male rhinoplasty patients, it's like screaming, like just red flags. You have to be very, very careful because those can be difficult. So you always watch out for unrealistic expectations. Body dysmorphic disorder in the general population runs like 1 to 2%, and the plastic surgery population is upwards of 10 to 15%. So it's tenfold. It's like 1,000% higher. So why is that important? Because you're not going to be able to make these folks happy. And I actually tell people, I'm not going to be able to make you happy when I feel I shouldn't be operating on them. Or I just tell them at a price that's way too expensive and they leave.
An important part of Dr. Markarian's lecture was the topic of Botox and fillers. Since large groups of people use this product for beautification and other medical purposes, Dr. Markarian took time to explain the correct application of this treatment and the importance of using a certified surgeon when administering these products.
Botox and fillers, again, I go for subtleties. Here's some cheek augmentations with Voluma. You can notice just some improvement in the cheek area. Voluma is a hyaluronic acid-based filler, lasts up to a year and a half. There's complications with all of this. A friend of mine wrote a book, and whenever he gives talks, he says the danger lies in not knowing the anatomy, and not knowing the anatomy is when essentially there's the vasculature of the face is so dense that if you don't know where the infraorbital artery is, when you don't know where the angular artery is, these are arteries that you're putting fillers and you're injecting all these hyaluronic acids in, you can embolize this acid, you can embolize this filler. By that I mean you can put this filler, gets an artery, goes to the end, whatever it's supplying, and for the lack of a better word, kill it. You can go blind from putting a filler underneath the eye that goes in the infraorbital artery. You can have, and I've treated patients who've had complete skin slough. They come into the ER where they occluded the vessel or they embolized the filler to the lip, and the entire lip and cheek started sloughing off. You have to be very careful. Whenever I inject into the cheek, I inject, go down for, say, something like Voluma, where you're actually trying to expand the cheek volume. I go down all the way to the bone and I pull back on the syringe. If there's a hint, just a hint of red, you pull the syringe out because you could be in a vessel. I ice them before I do that. It serves to reduce risk of bruising, but you're effectively reducing the target you could hit. It vasoconstricts all the blood vessels. There's a lot that goes with it. And I mean, one of the biggest money makers is non-invasive cosmetic, is Botox and fillers. And most of the people that do it aren't physicians. They go to a weekend course, they see the anatomy lesson on PowerPoint, and they say, well, I can do this, so let's do it. And some of the times they do a fine job. I mean, I know a lot of non-physicians do great jobs. But it's those patients who don't really understand the anatomy who can create problems. I'm intrinsically biased as a plastic surgeon because I operate in this area. When I do a facelift, I operate here. When I do an eyelid surgery, if a patient comes in for trauma, every time I sew up an eyebrow, sew up an eyelid, sew up a nose, I can see the blood vessels. Patient cuts their lip, I know where the superior labial artery is. It's hard for me to understand how patients who don't see the anatomy inject reliably or with 100% comfort, because even though I see the anatomy regularly, like right in front of me, I'm still extremely cautious every time I inject, because what I think in the back of my mind is, What if I get this artery? What if it embolizes? What if something irreversible happens? So there's a lot that goes into it.
Promoted by a question from the audience about plastic surgery done by celebrities, Dr. Markarian also spoke about the dangers of having the pre-figure resorting and unnatural looks.
You can pull things too tight. You can pull things in different vectors of pull that aren't natural. And a lot of these patients, and I think in the case of Renee Zellweger, she not only got a facelift, but she got a lot of volume. She got a lot of fillers or got a lot of fat grafted at the same time to accentuate it. You think about a deflated balloon, you can tighten it, and you can also fill it up with air. A facelift that doesn't look good, maybe is too puffy, is something that was tightened up, and that tightened area underneath the skin now is more likely to get inflated if you put a filler in, for example, and get distorted if you put a filler in, or fat. Filler is just typically some kind of a derivative of hyaluronic acid that allows you to plump something up, whether it's a face, a cheek, a lip. You can use fat instead. So these are different things you can use. If you do things too tight, it puts tension on the wound, puts tension on the scars. These are all fundamental principles of plastic surgery. You want to put your skin incisions in relaxed skin tension lines, areas that aren't noticeable. You want to reduce tension on closure with multiple layers of closure. You know, maybe the skin was pulled too tight. They didn't adequately put the incisions in areas that they should have. There's all these things that happen. But also, in time, skin relaxes. So you might not have long-lasting results, but that wasn't what you're asking about. It was just the initial results. It distorted what she looked like. Well, I mean, even if I was to just, on myself, if I was to tighten my face, there's a limit above which you can just, at some point, it will distort things. And if you distort things enough, and then you add volume to it, you can easily obscure someone's, I mean, she was unrecognizable. So it's also what goals you really want.
Another topic discussed by Dr. Markarian was breast augmentation and breast lifts.
I do a lot of breast augmentation, and these have a lot to do with, breast augmentation has a lot to do with breast position when it comes to the areola position, how inflated or deflated they are. You have to pick the type of implant that you want. I'll always do silicone implants. There's textured implants. I don't do those. I do smooth implants. There's data out that textured implants can create a fluid collection that can have leukemia in it. ALCL, 1 in 150,000 patients can have that. Textured implants were something that people used to do before. I don't. Very few people do it now. There's a lot that goes into it. It isn't just putting an implant in someone and you're done. The difference between a breast lift and a breast augmentation, you're putting in an implant, but a breast lift, you're sacrificing position for scars. Whenever I do a breast augmentation, a breast implant, I put an incision right underneath the breast fold. It's about 1 inch. When it comes to a breast lift, depending on how much you want to lift it, you can do anything from what's called the donut incision, which is just a circle around the areola, to the full anchor incision, which is around the areola, vertically down and underneath the fold. When it comes to breast reduction, this has the highest satisfaction rate out of all plastic surgery procedures. For neck, back, shoulder pain, you see patients with shoulder grooving, notching from the bra straps because just the intrinsic weight from the bra. You use all kinds of incisions. This is very similar to a breast lift incision in that you are excising skin with a breast lift. With a breast reduction, you're excising skin and breast tissue to create the new breast, lowering the burden.
In addition to aesthetic procedures, Dr. Markarian shared with the audience his experience working with patients with medical conditions such as hernia or hand injuries and deformities.
I do a lot of complex hernias, patients who have hernias with diastasis and separation of the muscles, sometimes have to actually get their rectus muscles reapproximated and closed. These are diagrams that show that. You actually cut the muscles above and below, you put mesh in between them, and then you reconstruct them to fix the hernia. Like I said, I do a lot of hand surgery, a lot of hand trauma. Patients who have cuts on the small finger, who can't flex their finger, tendon retracts, at different zones of the hand require different surgeries. Here you have multiple different structures involved. You can have both flexor tendons, you can have the pulleys, you can have arteries, you can have nerves, and you reconstruct all those. So one day I'd be doing a breast augmentation, the other day I might be repairing an artery and a nerve under a microscope.
The event concluded with an engaging Q&A during which Dr. Markarian answered many questions from the audience. This informative and very relevant lecture was yet another example of the kind of work AAHPO is doing to serve the medical needs of our Armenian diaspora as well as the motherland.